All right, let's get into drugs that are used to treat bipolar disorder. So these are our mood stabilizers primarily, but as you'll see, also some antipsychotics and other medications. So with bipolar, as many of you know, there are some differences from unipolar depression that are worth knowing. So obviously, other than the manic episode, which of course differentiates them, for bipolar, typically you see an earlier onset and a more acute onset. So onset typically happens before age 25, but can happen, often you'll see first symptoms around 15 to 19 years old. You'll have more total episodes. It's a stronger familial relationship with mania, which kind of made sense. One of the things as we'll see about on the next slide for bipolar 1 that really differentiates from depression is you have an equal ratio of men to women. So you have just as many men as women having bipolar 1, which of course is very different for depression. So overall, the prevalence is about 1% of the overall population. For bipolar 1, we see an equal male to female ratio. For bipolar 2, we see more females than males. And as I mentioned earlier, you'll start seeing symptoms often around 15 to 19 years old, but there's often a long delay before correct diagnosis and treatment. So this is one of the things I typically have us debate in class, but there are many reasons potentially for this. But one is that often people are not going to come in until the first depressive episode. So while mania can cause a lot of trouble, there's a lot of benefits to mania. People are often very goal-driven, very productive. Mania may feel really good. Well, it does feel really good. It's not something that people are going to, on their own, complain about as much. But depression, of course, that will bring them in. So that delays the time to actually get an accurate diagnosis. We have a very high suicide rate for bipolar disorder, unfortunately. Between 25 and 50% attempt suicide, and roughly 10% will die by suicide, is at least one estimate. All these estimates are really hard to get accurate, but given that very, very high suicide rate, much, much higher than depression, several magnitudes higher. So, why is that? Well, there's the old theory that I still kind of like, which is that, people are more likely to attempt suicide when they're starting to come out of a depression than when they're at their greatest depths. And part of that is because they may have those thoughts, but they may not have the energy or the will at the worst stages of depression to actually act upon them. And so with that, when people start getting feeling better, they may still have those thoughts, and they may now have the energy to act upon them. Likewise with bipolar, you may have it where someone still has those suicidal thoughts, but as they transition from depression toward mania, now they have that energy that may enable them to act upon those thoughts. So that's just one theory, but regardless, you do see a very high suicide rate in bipolar, so it's something you have to be aware of. The other thing that's worth noting is that the depression you see in bipolar is typically a much more severe depression than you'll see in standard major depression. So, how do these drugs work? One of the things you'll notice, if you thought that we didn't know much about antidepressants and antipsychotics and those medications, we really know very little about the rest of the medications we're going to talk about this semester. And mood stabilizers really are no different. It does seem that there seem to be some neurobiological actions that they have in common with antidepressants. So looking at imaging and postmortem studies, you see similar structural changes in the brains of individuals who have been diagnosed with bipolar disorder. Specifically, you'll see reductions in volume in the prefrontal cortex, hippocampus, decreases the number of neurons. So there seem to be changes that you see in depression that you also see in bipolar disorder. So likewise, as we talked about, one of the theories for antidepressants is that they may be neuroprotective. And the same thing goes here. The leading theory is that mood stabilizers, like the antidepressants, may actually reverse some of the impairments through being neuroprotective. So they help people keep the neurons they have and recover. So with this, just something to think about. If this is true, why is the relapse rate so high? We're going to get into that. But the thought is that mood stabilizers may reverse the impairments in brain structure and also in BDNF. So BDNF is brain-derived neurotropic factors, and these support existing neurons and encourages new ones to develop. So this could be relevant to their therapeutic benefit. And in laboratory models, lithium was actually found to protect neurons against a variety of toxic agents and promoted the growth of neuronal processes. So with that, when you give rats lithium, they're going to show less neuronal death when given toxins, and they're more likely to show neurogenesis. So how do these drugs work? Again, we don't have a great answer to this. So currently, the most studied mechanism we have is that they seem to be working with second and third messenger systems in some way, but they seem to be affecting intracellular processes through activation of G protein receptors. And we'll talk, each drug acts a little bit differently, so we'll talk about what's hypothesized, but overall our thought is that it's changing the way that these neurons are communicating together through modifying intracellular signaling pathways. How's that for being vague and generic? So, clinical issues. As we mentioned, the patients that seek treatment seek it for depression. And because of this, and because often, well, there are many reasons. Often, someone that comes in for depression, they're not going to be seeing a mental health provider. They're going to be seeing a general practitioner most often, who may have 6 minutes with the patient and may not have the time or the ability to screen for everything you normally would. So often, patients aren't fully screened for mania and everything like that. So only 20% of patients who screened positive for bipolar actually received the diagnosis, but 31% received unipolar, 49% received no diagnosis. So we're not overly good at identifying bipolar and providing the proper treatment. That's one of the issues we have. And as I mentioned before, there's a significant delay between the onset of symptoms, the correct diagnosis, and the treatment. And then we talked about suicide rates being higher. So there are 4 main classes of treatments that we see for bipolar. Sorry, my cat jumped up here again, so you may see him a little bit. Lithium's the old tried and true method, and it's a heck of a medication. We'll go into lithium. Then you have the anti-mania anticonvulsants. So these are things like DEPAKOTE, I don't know why I have DEPAKINE there, that's DEPAKOTE, TEGRETOL, LAMICTAL, topramats, a lot of those you probably have heard of. And then antipsychotics like Zyprexa, risperidone, we'll talk about those. And then omega-3 fatty acids, my favorite, fish oil. You know I love fish oil. I have one slide briefly talking about it, but there's not a lot to say with it. So, lithium, great drug. Been around forever. It's a natural element. Really effective drug. So it's, for acute episodes, about the best that we have, honestly. It's effective in 60 to 80% of acute episodes, which is pretty darn good. The problem is if it's rapid cycling, not as good. So it's only effective in about 30% of rapid cycling cases. Also, at least a third relapse. And honestly, a third is a very kind estimate. It's like, in many states, it's much higher than a third relapse. So it's very good at acute episodes, but you're very, very likely to relapse. So the thing that has been shown time and time again is efficacy in clinical trials is much better than actual effectiveness in actual clinical practice. So why is this? Well, what we see, and we've talked about this with other medications, compliance is extremely poor. So it doesn't matter how good your treatment is if people won't do it. So the side effects are often intolerable for clients, and one of the biggest things we struggle with bipolar, and it's a huge thing, is that mania feels good. Mania is fun. Mania is not something people often want to give up. So people will miss the highs of the mood swings. And because of that, it makes it hard to want to take a medication that's going to take that away. So lithium is a naturally occurring element. It's actually excreted unchanged by the kidneys, and it's not metabolized. So with this, it doesn't really affect the liver. Liver's not a big deal. Kidneys are a big deal. So a couple things. Lithium we've talked about before, when you're on lithium, very cheap medication, so it's still used. It has its place. Again, it's really great for acute mania. But you have to really watch the blood levels. Now, with it being primarily excreted through the kidneys, if you have kidney damage or kidney disease, that's going to be an issue. That's going to slow down your ability to get rid of the lithium and lead to higher blood levels. Also, fluid imbalance. You can actually overdose on lithium by exercising too much and throwing off your fluid imbalance. So those are things to keep in mind with lithium. So overall, what are the clinical effects we see? It decreases the number, frequency, and intensity of episodes. It shortens the duration of episodes. Overall, we see a subtle transient, we see a decrease in subtle transient mood swings between the episodes. One of the things to mention is even though it's good for acute mania, it takes a decent amount of time to work, about 5 to 10 days to show a response. But once it shows that, about 2/3 of people show a good to excellent response, and 80% show an adequate response or partial response. So a lot of people respond to this, and it's great for acute, but for longer term treatment, it's not as great. So usually for maintenance or prevention, you typically want to have a second drug on board and not just be reliant on lithium. So again, with this, it's good for the acute phase. Lithium's not very good for mixed atypical or secondary mania. It's still a primarily used treatment. It's a first-line monotherapy for acute bipolar depression, and can also be used for bipolar prophylaxis. So with this, this will be like when someone's asymptomatic and you want to keep them that way. That's what we mean by prophylaxis here. And so you can use it for bipolar depression prophylaxis. It's good for that. But what we're seeing more and more is all these medications actually being used in combination with others. And we'll get into that as we go on later. But really, if lithium, I would say its claim to fame is acute mania. It does very well with acute mania, probably the best drug we have for acute mania. There are side effects. Tremor, you can have cognitive impairment, nausea, weight gain, increased urination, which is problematic because of the kidney stuff that I told you about. Hypothyroidism, you can have toxicity, as I mentioned. It can be done just through too much exercise and too much excreting liquids. And you can also have Epstein's abnormality, which is a heart defect in children. So with this, it is teratogenic. You don't want to take this while pregnant. We'll get into what to take while pregnant. Lithium is not what you want to take while pregnant. So I think this is just an amazing drug. So this is looking at the quality of evidence for mood stabilizers in bipolar, looking at acute mania, just overall prophylaxis, and then acute bipolar depression. And what you'll notice is across the board, lithium's hard to beat. Lithium is a very, very good drug. It's, cheap as dirt because it's a natural element. You can't patent lithium. There are the limitations with the narrow therapeutic index where you have to watch the blood levels, but it's a very good, effective drug. There's nothing wrong with lithium. Anticonvulsants. So, anticonvulsants are often used for mood stabilization as well. And with this, they're also used for a lot of different things, like treating relapse to substance use, and you're seeing anticonvulsants used more and more in different disorders, controlling aggression, PTSD, seeing them used more and more with kids. So, this bipolar is just one of the many potential indications for anticonvulsant mood stabilizers. So how does one class of drugs solve all these problems? Well, the answer is neuronal membrane stabilization. I read it as we don't really know. But, we'll get into how these drugs work with each. But long story short, my reading of the literature, we don't fully know why these work or how these work. All the drugs are similar in some way and yet different, as you'll see. And some of the drugs affect affect and are antidepressant, others are not. So when you look at antipsychotics in relation to mood stabilizers, there are a lot of things that are similar. So both types of drugs are antibipolar. They both treat aggression and violent behavior in a lot of different situations, and both have effective actions that may be beneficial. So with that, it's not surprising that both mood stabilizers and antipsychotics are both commonly seen in the treatment of bipolar disorder. So the first medication we'll talk about is TEGRETOL. So TEGRETOL is as effective as lithium, but we really don't see it much anymore because of the side effects, as you'll see. So the mechanism of action is it's going to inactivate voltage-sensitive sodium channels. So it's going to slow down activity in the brain because it's going to make it so the sodium channels are deactivated and not as sensitive. But with this, that doesn't seem to be the reason it has an effect in bipolar disorder, because efficacy takes longer than that mechanism to work. So that happens, but it still takes significantly longer to actually see a clinically significant effect. So adverse effects, as you can guess with something like this, it's going to essentially be a depressant. You can have some sedation, ataxia, visual disturbances, cognitive impairments. The biggest thing is Stevens-Johnson syndrome. So this is a really nasty disorder that we're going to see in a couple of these medications where the epidermis separates from the dermis, which is very, very rare, but very bad. It's often a life-threatening disorder. So very, very bad disorder to have. So because of this, well, there are other problems too. Here are other problems with TEGRETOL. A lot of drug-drug interactions. It also induces its own metabolism, leads to liver toxicity, leads to hematological problems such as reduced white blood cell counts, has a black box warning, and requires frequent blood monitoring for toxicity. So because of all these problems, Tegretol is really not used much at all anymore. Excuse me, I'm sorry. So this leads us to Trileptal. So Trileptal has pretty much replaced Tegretol for pretty much all uses. It's been shown to be superior to placebo in the treatment of acute mania, but one thing that's important to know is it doesn't outperform placebo in kids. So Trileptal is probably not your best option for kiddos. There are many things that are good about Trileptal. It doesn't have the enzyme induction in the liver. It doesn't have the white blood cell problems. It doesn't have the liver problems, so you don't have to do all those blood tests. But there are, side effects, so tiredness, headache, dizziness, ataxia, some allergic reactions. And while it's not fully clear, it does look like it does have some teratogenic effects. So you're not going to want to be pregnant on this medication. Valproic acid, or DEPAKOTE. So this drug breaks down sorry, I can't read. This blocks the breakdown and reuptake of GABA, and may also suppress sodium channels and affect gene transcription. So we have a lot of thoughts on how DEPAKOTE works. We don't fully understand it. But it's used to treat acute mania, mid-states, rapid cycling bipolar. You're going to see it used a lot. And it does work well. Actually, one of the primary times you see it is for people that don't respond to lithium. And of those people, 70% respond to DEPAKOTE even though they didn't respond to lithium, which is great. And often what you'll see is a combination of DEPAKOTE with lithium or with olanzapine in order to try to maximize the effects. So there are problems with DEPAKOTE. You see actually fewer side effects than the other drugs. You have less cognitive impairments. But one of the big things you do see, much like what we saw with the antipsychotics, is weight gain. You do see weight gain, GI problems, tremors, sedation. You can have hair loss. You have an increased risk of PCOS, which leads to menstrual irregularities, acne, male pattern hair loss in women. So that's something to consider. And there's definitely a link with neurotube defects, especially spina bifida, in the first trimester. So you don't want to be taking this if you're pregnant. And also, you do have to be careful because you can overdose on DEPAKOTE. So you can lead to coma and death with overdose. LAMICTAL. If it will flip. There you go, LAMICTAL. So LAMICTAL's a good drug for certain people, as we'll talk about. So what LAMICTAL does is it blocks glutamate sodium channels, which leads to an inhibition of glutamate release. So it's going to, again, like a lot of these drugs, be overall inhibitory. It's as good as lithium is at preventing manic relapse. So that's the good news. It's actually better than lithium at preventing depression relapse. It's not good at all for acute mania. So this is something you're not going to use for acute mania. You're going to be using more for prophylaxis, for prevention. But you're not going to use this in the middle of a depressive episode or manic episode. Well, maybe depression, but not manic episode. The problem that you run into with LAMICTAL is, again, that Stevens-Johnson syndrome. That's a really bad skin disorder I talked about. And you see a very high rate of it in adolescents. So 1% of adolescents will develop this side effect. And while that's not a huge number, it's a very severe side effect. So what does you almost always want to avoid giving LAMICTAL to adolescents because of that. Now, there are, as I mentioned, some very notable benefits for LAMICTAL. One is with cognitive functioning. So they had a pretty good sample of both individuals who were manic and those who were depressed that were on maintenance doses of LAMICTAL as monotherapy after they discontinued their other drugs. And one thing that was interesting is, I've mentioned with so many of these drugs you have cognitive problems. Both groups actually showed cognitive improvements, but those who were manic most recently showing more improvement than depressed patients. And when people were switched from other medications, they also saw cognitive improvements, even after correcting for improvements in mood. So, if one of the problems you have with adherence is cognitive issues, then LAMICTAL may be the drug to switch to, because you're going to see fewer cognitive issues with it. The other time that's absolutely the drug to consider is if you're pregnant. So, with this, there's a longitudinal study, and what they found is that the risk of major birth defects with LAMICTAL was basically the same as in women who were not medicated. Whereas for the other monotherapies, you saw about a 2 to 3-fold increase in birth defects. So because of that, LAMICTAL is usually the drug of choice for pregnant females with bipolar disorder, because it does seem to be pretty safe from what we can tell from the research so far. Now, moving into antipsychotics, before I go into these, I must tell you the slides I just posted, I've moved around a little bit, so don't let that throw you off. So, traditional antipsychotics are effective in mania, but much like they are with psychosis, they're limited by their neuroleptic side effects, so they're not used all that much. Atypical antipsychotics that are being used more and more. Clozapine is especially being used because it's more anti-mania than antidepressant, so it's a nice fit for being effective for mania. Whereas risperidone, which we'll also see, is more of an antidepressant, and it may actually aggravate mania. So, overall with the antipsychotics, what we're going to see is all of these drugs are effective for mania. And here are the studies to show it. So here you can see all of them, they differ in exactly how strong of an effect, but all of them are significantly better than placebo as far as effects on mania. And similarly, this is looking at ratios of 50% improvements, and you can see all of them have a significant improvement above no effect right here. So one of the things you're seeing a lot more of nowadays, as I mentioned, you're seeing a lot less monotherapy. You're seeing a lot more of, drugs being combined. So the new thing here is we're taking drugs that we already have, combining them, putting them in the same pill, and giving them a new name. So, for instance, meet Symbiotes. So Symbiotes is combining Zyprexa and Prozac. That's all it is. It's just putting those two in the same pill. That's all Symbiotes is. And you can see there are different dosings depending on how much you want of each medication. So since this is just those medications, you see the same interactions, the same drug effects as you'd have with both of those drugs alone. So with this, you're going to have, you can have hyperglycemia, diabetes, CVAs, hypertension. You can potentially have tardive dyskinesia and those sorts of problems because of the olanzapine. You have a lot of weight gain, which is an issue, and you also can have sedation. We won't talk much about fatty acids. I'd love to because, again, I love fatty acids. But initial results were really great with bipolar, but the more recent studies have been inconsistent. So there's just not enough research there to support their use at this point, in my mind. So to kind of wrap up, we're going to look at the STEP BD study. So this was similar to some of the other large treatment studies that we've looked at with other disorders, looking at essentially for how effective is treatment and how do people in the real world actually respond to treatment. So with this study, we had a very large number of patients, and what we saw is out of 4,360 participants initially, only 1,469 actually made it 2 years. And of those, only 58.4% actually got to recovery. So even the small subset of people that made it, only half of those people actually made it to recovery. And during the 2-year follow-up, about half of those people had a recurrence, more likely to be a depressive episode than a mania episode. And recurrence is more likely in those who had had residual symptoms at recovery or additional psychiatric issues. So what's this telling us? What this is telling us is we have medications that are effective. The studies we've looked at showed that. For a lot of these, 70-80% effectiveness is not out of the question. But we have medications that people struggle with adherence. People struggle with it because they miss the mania or they don't want to deal with the side effects. But adherence is a significant issue. And I think a lot of the reason why you see such high relapse rates and fairly low real-world recovery rates is because of that adherence. So with that, there are non-drug therapies to consider. I'm a big fan of just plain old psychotherapy. I'm a psychologist, that's probably why. But there are other treatments out there for bipolar. But I think psychotherapy makes a lot of sense just because, again, a lot of the issue we are running into is adherence. So looking at overall treatment of bipolar is very hard. So with mood stabilizers, they're often augmented with psychotherapy, antidepressants, ECTs, something like that. The thing, though, is you want to have a mood stabilizer on board. So if you don't have a mood stabilizer, add a mood stabilizer. If you have someone coming in with bipolar that's not on a medication, send them to a psychiatrist. You're not just going to do psychotherapy with us. So once you have the mood stabilizer, what you do after that is a good question. You can add an antidepressant, but it's whether or not you want to, it's complicated. So your efficacy is not great. So about 50 to 70% show a response with an antidepressant, which is good but not fantastic. But it may induce someone to switch into mania. So you have to weigh the risks and the costs. From where I'm sitting, I really like psychotherapy. Again, I'm biased. I'm a psychologist. But again, so much of what you're seeing is a problem with adherence. That's something that psychotherapy can help with. Plus, you can help with the depression side of things with psychotherapy as well, without having someone switch to mania. So, for my money, I like psychotherapy. But, again, just know my inherent bias given my profession.